Welcome back. Well, again, we have new guests with us, two new guests, one returning guest. I'd like to introduce Dr. David Ayers. Dr. Baima, thank you for returning with us this segment. And Dr. DeMarco, we saw your story and very inspired by it, so we will be speaking with you about your personal experience. I'm going to first swing it over to you, Dr. Ayers, because you have a wealth of knowledge on this. So when people are coming to see you, what stage are they in this whole process?
So Colleen, when people come to see me in the office, there's a wide spectrum of stages that they're in. Some come fairly early in the process to learn more about the disease and ways to try to modify the course. Others are in a middle zone, and some are quite advanced who have very, very severe arthritis, have already tried exercise, diet, activity modification, and medications, and are really coming specifically for surgery. So there's a wide spectrum of patients that I see.
Okay. And what do you tell them? I mean, when you know that they're at the point that they do need to seek treatment, how do you go about that, and what are you looking for?
So patients who have severe arthritis, we're really trying to evaluate the impact it has on their life. Mm-hmm. And the two major factors are the amount of pain that they have and how it affects their function. Okay. Because that's the two things that really affect the patient's ability to do the things they want to do and to do the things that they have to do. So we want to know how much pain they're having, try to quantify that, how that reacts to treatments that they've tried. And typically for patients who are thinking seriously of surgery, they have pain that cannot be controlled with the other treatment options, and they have very severe limitations in their ability to do the things that they need or want to do. Okay.
You have some, I hate to call them props, but examples.
I do, yes.
That maybe you can show us in this form. What are some examples or studies that you're looking for?
So this is a model of a knee. And arthritis is when the cushion or the articular cartilage between the two bones, the thigh bone or the femur and the tibia bone or the shin bone, when the spacer, which is the cartilage between them, wears away so that the bones rub on each other. I mean, it's easy to understand why that's such a painful condition, because there's no cushion left and the bone actually rubs against the other bone. Causes swelling, causes pain, can cause deformity and lack of motion. What a knee replacement is removing the damaged cartilage on the end of the bone and replacing that with a metal cap on the femur, a metal tray on the top of the shin bone or the tibia, and then a plastic spacer that goes in between. So it's a metal, plastic, metal sandwich, which is really only about 1 inch in thickness. Some people think a knee replacement is replacing the knee from here to here, but it's really just a resurfacing of the joint so that we're replacing the damaged cartilage or cushion with an artificial cushion that is really this plastic metal sandwich.
Okay.
The last part is the kneecap.
Yep.
The kneecap is within a tendon in the front of the knee, and it slides up and down a groove in the metal tray, the metal runner here. And there's often damage, severe damage on the cartilage on the back of the kneecap. And we retain the bone of the kneecap, but we remove the damaged cartilage and put a plastic spacer on the back of the kneecap as well, which slides in the metal groove on the femoral cap.
Okay. Dr. DeMarco, is this looking familiar to you?
Yes, unfortunately it is.
Maybe you can, again, we heard a little bit about your story, but what he's explaining and the pain symptoms. Talk about your experience.
Yeah, so I, as you heard from the earlier video, I was a long distance runner. I was a marathon runner for a very long time. Never had a major injury, but have a family history of osteoarthritis, and I started to have pain while I was running. Eventually had to stop running, but still had pain at night, really couldn't even walk my dog around the block. So, tried the usual things that you and Dr. Upchurch mentioned, anti-inflammatories, exercise, quadriceps strengthening, steroid injections. I think you did a Synvisc injection. And I actually had arthroscopy as well to sort of clean out the joint. But you know, eventually it reached a point where I kind of felt like I was ready because it was interfering with my lifestyle.
Dr. Baima, is this typical where she obviously was in good shape, an athlete, a runner, and things just were not working as they properly should in the knee area?
Absolutely. I think this is another frustrating issue for patients because all the time I get, doctor, when do I need a knee replacement? Well, I turn that question back around and say, how are you feeling? You know, how bad is your pain? Can you go upstairs foot over foot, or do you have to bring one foot together when you're trying to do stairs? You know, for someone who's running 26.2 miles, you know, that's a very active person that's going to realize a different level of function than someone who is homebound, who isn't really getting out of their house. So we need to take into consideration what the patient was doing before and ask them, has this changed? Is the pain occurring earlier in your runs? Are you able to run anymore? You know, when you switch to biking, does it still bother you? Can you do the stairs to get into your house? These are the types of questions we ask. And we want to know, are you having daily pain? That's another important question that's really helpful to us in helping the patient make that decision. But I would say we typically reflect those questions back because it is the patient's decision. Sure. We manage the symptoms more so than the radiographic findings.
Okay. Dr. Ayers, you wanted to add to that.
I think that's an important point, that there's never a time when you have to do a joint replacement, when a professional, a physician should tell you, we need to replace you have to have a joint replacement. It's always an elective surgery. The elective means that you have a choice. And how you make that decision is difficult. All those questions that you've heard are very, very appropriate. We are also at UMass Memorial one of the leaders in the field in helping patients with this by providing them tools. And we have a computerized patient questionnaire that's validated and been used by hundreds of thousands of patients that can grade the patient in terms of where they are versus age-matched controls, people their age who do not have arthritis, and they can look at the severity of their disability, the limitations of their function, as well as the severity of the pain, because for each individual patient, they don't have a frame of reference. But by using these types of validated tools, which are now available online as well, we can help the patients understand where they fit in the spectrum of the disease process.
Before we get into more information about the surgery, I'm going to have you show us another prop, this one of the hip, correct?
Correct.
So this is another joint that can exhibit itself in terms of pain and replacement with this condition?
So the two most common joint replacements performed in the United States today are the knee replacement, number one, and the hip replacement, number two. Together, there's roughly 1 million joint replacements done per year in the United States.
Wow.
You know, a very, very large problem. The hip replacement, arthritis is similar, that there is no cushion. The articular cartilage has worn away. The hip is a ball and socket joint. So it affects the articular cartilage on the ball as well as in the socket. So the joint replacement itself makes up a plastic sandwich, again, to replace the cartilage. Here there's a metal shell which fits into the pelvis, into which a very high density, very tough polyethylene liner fits. And then there's a metal ball that replaces the femoral head, or the ball that's at the top of the femur, the thigh bone, which is attached by a stem that goes into the thigh bone. So the hip replacement looks like this, again with a metal sandwich. And on the metal that goes into the bone, there is a roughened surface that has a sandpaper finish. And the surgeon will fit this very precisely into the bone so that it has intimate contact up against the bone inside the femoral canal, which is the middle of the bone. And bone will grow into this sandpaper finish. So the patient's own bone grows into this metal porous coated surface, and that provides long-term fixation of the metal to the bone.
Dr. DeMarco, I know this, not the hip, but looking at the various steps that go into the surgery and what needs to be done in joints, how did you prepare for this surgery?
Yeah, that's a very important aspect of the whole procedure, and it's one that we as rheumatologists discuss with our patients. For me, it was really a 6-month process because of coverage that I needed at work. But for many patients, it's getting in shape if they're not already in shape. One of the hardest things, losing weight. I wasn't really in that category, but it was arranging my kids' lives. You have to donate blood, or you have the choice of donating blood. So it's not something that you make a snap decision about. So it is quite a lengthy decision-making process.
Right, and as you mentioned, you're a doctor in the UMass system, so you are up on the medical terms, the understanding of the field, but it sounds like it still was, taking the doctor's hat off, right. A very personal decision, and one that, can you imagine, for someone that doesn't understand this field, a difficult decision?
Yeah, I think it was really important for me to take the doctor hat off because everybody assumed that I knew, the whole process that was involved, and I actually didn't. So I did behave like a patient. I went to the class that's run by the physical therapist, which was excellent. It told you what to expect, right after the surgery, what kinds of assistive devices you would need at home, like a walker or things in the bathroom, and that was really helpful. I wouldn't have known that, and so now it's helpful for me to tell my patients about that. But
Sure.
But I think it was important for me to remove the doctor hat.
Absolutely. And Dr. Baima, how do you prepare just the average person out there who is getting ready for the surgery?
We talk about some of those things. First, we make sure they have an understanding of what the cause of the pain is. Like Dr. Upchurch mentioned in the previous segment, we make sure there are no other factors. Is there some other underlying process related to this? And then if this is osteoarthritis, how bad are your symptoms? We go through that whole conversation. And then are there any modifiable risk factors, weight being the most important one and the most obvious one. And then just strength and muscle tone. Okay. Also involving the family members. For example, my mother's had both of her hips replaced, not at the same time. Typically, that's another question I get. Typically, joints are replaced one at a time. It's not one-stop shopping. Wouldn't that be nice and easy? But it's much harder to rehab, let me tell you. Yeah. So my mother had her hips replaced one at a time, and it involves the whole family. Do you have stairs in your home? Do you have family support? Just to get back to things in the bathroom, lest we joke about that, what Dr. DeMarco means is, for example, if you have a hip replacement, you can't have your knee higher than your hip to protect that surgery. So what you need to do is have a raised toilet seat. So that's the thing in the bathroom that you need, should anyone call in with that question.
Good note, good note. Dr. Ayers, what is the success rate? Again, these are elective surgeries, but very necessary. So what can people expect?
So these are the most successful operations we do in medicine today. They're relatively new. If you look at the history of medicine, hip replacements began in the mid-60s and became popularized in the mid-70s. Knee replacements began in the mid-70s and became popularized in the mid-80s. But they are among the most common operations done in the United States today because they are so successful in relieving the severe pain of arthritis and improving the patient's function. So that's why there's been an explosion in the growth of these operations. Virtually everyone knows someone in their community or in their family who's had one of these, and many people consider it one of the miracles of modern medicine.
How long does this last? Is it a one-time operation? Do people have to go back in?
So these are lasting longer as we improve the prostheses. And let me go back to the model. I'll use the hip as a model. There are a couple of things that are important to the longevity of how long the prosthesis or the replacement will last. The first is, how is the metal fixed to the bone? Early on in the history of hip replacements, we fixed the metal to the bone with a bone cement. And the bone cement was a grouting agent, an acrylic. It worked very well, but that acrylic eventually fractured and loosened. These newer prostheses, where the bone grows into the metal, are much more durable and much longer lasting than the bone cement. So a modern hip replacement consists of a bone ingrowth fixation rather than cement fixation. And these last greater than 20 years.
Wow.
Both on the ball side that goes into the femur, as well as the cup side. So the weak link is the plastic that's inside the acetabulum or the cup. And this plastic, again, has been improved over the last 10 years. It's been modified, and it is much more durable than the original plastics that were used in the 1970s. This, we believe, will last at least 20 years as well. Wow. But it's made so that if the plastic does wear and fracture or fray, it can be removed so that the metal can stay in place and a new plastic can be put back in.
Wow, much less invasive.
Much less invasive should a second surgery be necessary.
Okay.
And similarly for the knee, again, the plastic in between the two metal runners is the area that can wear after years and years of use. And it's made so that this plastic can be taken out and a new plastic can be put in without having to take out the metal cap on the femur or the metal tray on the tibia.
Dr. DeMarco, that must give you a sigh of relief.
It lasts a very long time.
Dr. Baima, coming out of surgery, people just can't get right up and run or hop right back on that hip. So talk to me about the process that you work or the field works on getting people used to these replacements.
Absolutely. We know actually getting out of bed sooner decreases patients' trouble with breathing problems or heart problems. So we do try to get patients out of bed right away. But once we do that, they have to work within their restrictions. And it really depends on the type of surgery they have, what those restrictions are. I think Dr. Ayers can probably tell us more about that. But operating within those restrictions, having a raised toilet seat, which may start in the hospital room and then come home with you, and having some of those modifications to get up and around while staying within the restrictions, and then slowly strengthening the muscles and waiting for the incision to heal before we get into the more aggressive activities, which would be later as an outpatient.
Sure. And Dr. DeMarco, I know you're a great example of someone that was active before and still very active after. So how was that process for you?
Yeah, so that was actually the thing I was the most worried about, is what was I going to do, for exercise after the surgery. And really the physical therapy becomes your exercise. I remember asking Dr. Ayers, how soon can I go back to work? And he said, PT is your job. And that's true. I mean, if you really want a good result, you can't just, and I tell patients this, you can't just show up at the physical therapist's office twice a week. I mean, I was doing the exercises 3 times a week, but on the other hand, you don't want to be up on the knee and have it swell, because then you can develop scar tissue. So it's important to have a balance of the restrictions with appropriate exercise.
Okay.
And the other bad thing for me is that I was also a swimmer, and Dr. Ayers told me I had to stay out of the pool for 3 months because of concern of infection.
Okay.
So that was tough.
Yeah, tough, but glad to hear that you're back into it.
Mm-hmm.
Wonderful information. Dr. Ayers, do you have any closing thoughts, any closing remarks for someone that's watching this that may have a lot of questions about any type of replacement surgery?
I think that it's important for patients to understand that they need to explore all their options. Many patients become paralyzed by fear at the thought of an operation. And it's understandable that they have concerns, but they need to understand that there is help for them. And there was a time when patients were told, wait as long as possible, wait until you can't stand the pain any longer. And we now know that you can wait too long, that if you wait so long that you stop going to the store, that you stop going out with your friends, and if you stop driving the car, people are less likely to get back to these things after the surgery. And that's why things like the validated questionnaire that we use that shows where a patient is in their disease process in comparison to similar patients without arthritis is very, very helpful. So you can wait too long. You don't want to wait until you're so debilitated that your muscles are weaker, your range of motion is poor. You should seek medical advice, and you should look at all of your options. And with the advances in surgery, with the advances in anesthesia, we do not use general anesthesia any longer for these operations. And general anesthesia is when you have an endotracheal tube put down your throat, and you have a ventilator that breathes for you. The modern way to do this is with nerve blocks and spinal anesthesia. So the patient is breathing on their own. They can be as awake and alert as they want to be, or as sedate as they want to be. And after the surgery is over, these patients are out of bed the same day as their operation and beginning to walk and beginning to do their exercises right away.
Okay, great news and great advice. Well, I want to thank all of you, Dr. Ayers, Dr. Baima, Dr. DeMarco. Wonderful information and really so helpful for, I know, a lot of people watching out there. And that will do it for this Health Watch In-Depth. Thank you for watching. Again, this is presented by UMass Memorial Healthcare. I'm Colleen Bamford. Good night.